She's Associate Professor from Department of Physiology. Welcome, ma'am. Please take over. Today we have cases from Department of Physiology, Orthopedics, OBG and Ophthalmology. They include both the oral as well as the poster presentations. I will hand over this to ma'am. Please continue.
Very good afternoon, everybody. So I would a very good afternoon, everybody. There are very interesting cases today. 3 oral cases from the Department of Physiology, Orthopedics, and OBG, and 3 posters, 2 from OBG and 1 from Ophthalmology. And I would request all the participants to maintain time. For oral presentation, it's 5 minutes, and for poster presentation, it is 3 minutes. Okay. Followed by a presentation, there will be discussion, brief discussion. So I would request the first presenter from the Department of Physiology, Dr. Prachi, who is a postdoctoral fellow in the Laboratory of Vascular Physiology and Medicine, and she'll be presenting on screening development of transglutaminase 2 inhibitors and its derivative as anti-lung cancer agent by in silico and in vitro approach.
Yeah.
Good afternoon, one and all, and thank you, ma'am. So my topic of presentation is screening development of tissue transglutaminase inhibitor, and it's a derivative as anti-lung cancer agent by in silico and in vitro approach. This work is done under guidance of S.P. Madgi sir and Professor Kushal Das sir. So these are my content of presentation. Let's start with introduction. As we all know that lung cancer is the most common type of the cancer in both male and women. And almost 1 among 9 cases are because of this. And cancer in this cancer treatment, cancer metastasis or the cancer relapses is the main hindrance in cancer treatment. There are many reports suggested that there are proteins which are involved in this metastasis process of cancer relapses. Among them, this tissue transglutaminase, which is also known as TG2. It is a this protein is a member from the family tissue transglutaminase, and is particularly involved in cancer relapses and cancer metastasis process. Usually this protein is a calcium dependent protein, and it involved in a cross-linking activity, post-translation modification, or GT transamidation activity. Structurally, this protein has 4 domains at N-terminal domain, and beta sandwich and catalytic domain, and that C-terminal region, barrel 1 and barrel 2 region. And each domain has its own activity and which involved in a post-translation modification. Usually at normal calcium level or the normal cellular level, this TG2 is usually involved in a cell mortality, extracellular matrix, or signal transduction, or apoptosis. In case of cancer treatment or some other chemotherapy, the calcium level in cell will increase, and which will induce this overexpression of TG2. This overexpressed TG2 will lead to the pathophysiology or some diseases, some disorders, which include some neurological disorder like Alzheimer, Parkinson, or as I'm told that tumor invasion and metastasis process, some genetic instability. So with this aim and with this background, I framed objective. I target this TG2 protein in lung cancer. So objective of current study is screening of ligand molecule as potent TG2 inhibitor to perform multiple docking strategies to check the stability of protein ligand complex by using molecular dynamic simulation study and validation of this in silico study through in vitro on human lung cancer cell line. Materials and method. These are the softwares, databases, and tools which are used for this current study. These are all the in silico or the computer-based study, prediction-based studies. This is the flow chart or the procedure which I followed for this current study. This is divided into two parts, in silico and the in vitro. Major part is the in silico. The result from the in silico is validated by the in vitro assay. It will start, I did some screening of the drug molecule from the PubChem database. I screened almost 500 drug molecule from the PubChem database. So my initial data set contained the 500 drug molecule. I reduced this data set by filtering. The filtration criteria was IC50 value, minimum IC50 value, those from the category of TG2 inhibitors. So after the screening and log p-value, Lipinski rule, toxicity property, these are the filters criteria which I applied for the creating the final data set. So my final data set contain about only 30 inhibitors. These are from the these 30 inhibitors are from the TG2 inhibitor category. These are divided into three subcategories like the competitive amine inhibitor, reversible and irreversible. After the these 30 inhibitors were subjected for the molecular docking study. Protein were retrieved. That human TG2 protein was retrieved from the PDB database, that is the protein database, and protein was prepared for the molecular docking purpose. The grid was prepared. Grid is nothing but the creating the environment for the docking purpose. After the docking performance, the potent or the which compound showed a good activity in terms of the binding energy inhibition constant. That compound was taken for the MD simulation. MD simulation is nothing but molecular dynamic simulation study where we can predict the stability of that compound when it will interact with the protein and in vivo. So this is again one type of the prediction study. After that, after completion of the in silico study, which compound showed in all the terms best potent activity, I taken it for the derivative formation. Derivative of that potent was done with the help of the 2,4-dihydrobenzoic acid at the laboratory scale in the presence of the lacase. And the activity of the derivative and the potent molecule was done in vitro on human lung cancer cell line, that is A549, which was procured from the NCCS Pune, and MTT assay was performed. Four groups were maintained. First one is a control, second one is a standard drug molecule, then third one potent drug molecule which come from the in silico study and the derivative of that potent drug molecule. This concentration was maintained from the 0 to 500 mg per gram, mg per ml. Results. This is a 3D structure of human TG2 protein. Almost 687 amino acid residues are present in 3D structure. Helix, then beta sheets and hairpin loops are present in this structure. Resolution is about 2.8 angstrom. It indicates that this protein is a good for the in silico study, and it contains about 205 water molecule and other small molecule. Other small molecules is nothing but the metals and hydrogens. These are the 30 TG2 inhibitors from three categories. Each category contains 10 inhibitors: competitive, amine inhibitor, reversible, and the irreversible. Molecular weight and the IC50 value of each drug molecules were obtained. After performance of the docking on all the 30 inhibitors, we found that these three drug molecule or the ligands showed a good activity in terms of the binding energy and the inhibition constant. Among them, cysteamine showed a good activity in terms of the delta G by delta binding energy, which shows a 46.08 calorie per mole, and the binding energy minus 5.96 kilocalorie per mole. And it interact with serine A482 and the phenylalanine 147. These are the amino acid where the drug molecule interact. So as that cystamine showed a good activity in a docking study, so that molecule was taken for the MD simulation and it was performed in a Desmond software. This is the free software, and this is the energy plot against usually this Desmond software or in any simulation study, we will perform in a picosecond. So I perform for the 5000 picosecond simulation period, and it shows a consistent period throughout the simulation period with the energy minus 14.85 kilocalorie per mole. This is the MTT assay result, cytotoxic assay. The first figure is about control group. Second is standard cisplatin drug. Third one, cystamine, because it showed a good activity. And fourth one is a derivative of cystamine, that is cystamine 2,4-dihydrobenzoic acid. As in concentration increases, there is a cell turbidity, cell shrinkage, and a membrane bubbling. So it indicates that there is a apoptosis process or the cell death process. And both cystamine and the cystamine dihydrobenzoic acid showed a good activity and the minimum IC50 value at 500 μg per ml. At the end of the, I may conclude that TG2 is a multifunctional, ubiquitously expressed protein, and cystamine showed a better binding activity with a best docking score as compared to the all remaining TG2 inhibitors. Energy plot of this revealed that complex, that TG2 cystamine complex is stable throughout the simulation period, and the admit property of cystamine sorry, cystamine TG2 will obey all toxicity property, and it is in a minimal range. And both cystamine and the cystamine dihydroxybenzoic acid showed a good activity in terms of the cell cytotoxicity in A549 cell. Significance: TG2 represent a single target that can modulate multiple pathway and function in cancer cells, and thus inhibition can simultaneously deprive the cancer cell line. And this data also supports that derivative can also be used for the cancer treatment, and it can used as a target, or it can use as a treatment for the cancer relapses and the cancer metastasis process. The thing is that we should validate this on the TG2 expressing cell line. I did it on a human lung cancer cell line, but for the next validation purpose, we have to validate on the TG2 expressing cell line. Thank you.
Thank you, Dr. Prakash. It's a very interesting study. And for the benefit of the house, I will just ask you one question. Describe briefly what is this in silicone studies and how it is advantageous over the conventional drug development techniques.
Okay, in silico study is a predictive kind of the study where we can predict the in vivo and the in vitro activity on the computational background. We can also, in drug discovery, this is the initial phase where we can reduce the time and cost. If we know the structure of the protein, DNA or RNA, or even we don't know, we can predict the structure also. By using that, we can design a new molecule or the new therapy, new treatment for that. Apart from that, we can also predict the signaling pathway by this computational approach. This work is based on the computational drug discovery approach.
How will you carry forward this study?
Next part, as I said that I must validate this activity on TG2 expressing cell line. Apart from that, I have to go for the RT-PCR for the expression of this protein.
Thank you. If any questions, the topic is open for discussion. If no questions, then I request the next presenter from Department of Orthopedics. And the topic for presentation is revision totally arthroplasty using constrained vestibular liner, a case study.
Good afternoon, all. I'll be presenting a case on revision total hip arthroplasty using constrained acetabular liner. The operating surgeons were Dr. Girish Kurnapur, Dr. Rajkumar Bhagwadi, and Dr. Ashok Nayak. Total hip arthroplasty is one of the most successful surgical procedures in the field of orthopedic trauma and surgery. Internationally, the number of THAs is projected to increase by around 170% by the year 2030. Along with this, the absolute number of revision surgeries and associated complications also will surge. Complications after total hip arthroplasty can be very challenging for both the patient and the surgeon. In this case, a 45-year-old male presented to the orthopedic OPD with a history of pain in the right hip since 1 year. He had actually met with an road traffic accident 7 years back and sustained a right femur shaft fracture along with a right medial malleolus fracture, for which intramedullary interlocking nailing was done for the femur and CC screw fixation was done for medial malleolus. And 2 years later, bone grafting was done in view of non-union of the femur shaft fracture. 4 years later, he had sustained another fall and was diagnosed with right tibia fracture, for which intramedullary interlocking nailing was done. Patient had a pain-free period, after which he started developing pain in the right hip, which was insidious in onset, dull aching, continuous in nature, aggravated on walking, and relieved by rest. Initial radiographs revealed that patient had developed an avascular necrosis of the right hip joint, and the right side intramedullary interlocking femur nail and the right intramedullary interlocking tibia nail also was in situ. This is the X-ray that shows the avascular necrosis on the right hip joint. The patient underwent the femur nail removal, which was followed by a total hip arthroplasty on 24th of June 2020. These are the intraoperative images. The hip joint intraoperatively under dynamic fluoroscopy, the hip joint was very much stable. Post-operative period was uneventful. Sterile dressings were done on day 2, 5, 9, and 12, and mobilization was started. Suture was removed on day 12 and the patient was discharged. Adequate counseling was given to the patient regarding care. This is an X-ray of the second month follow-up, wherein a patient was very much comfortable. These pictures show that the patient was able to achieve around 45 degrees of abduction and around 60 to 70 degrees of flexion of the hip joint. This was at 2 months. The patient was able to walk at 2 months comfortably without any support. 3 months post-surgery, the patient presented in our emergency department with a history of self-fall under the influence of alcohol, and patient had complaints of pain in the right hip and was unable to walk. On examination, the right lower limb was in flexion, adduction, and internal rotation. There was no evidence of any neurovascular deficit. Radiograph showed that there was a dislocation in the hip joint, and patient also had sustained a right patella fracture. Patient was then admitted and all necessary preoperative investigations and workup was done, and patient underwent a revision total hip arthroplasty on 24th of last month. This is the pictures of the intraoperative procedure. We had removed the initial acetabular cup. This is the picture of the acetabular cup, which was removed. And we had done some reaming, and a fresh acetabular cup was introduced along with a new femoral head. The implant which was used was, we had used an acetabular system porous shell with cluster holes and constrained acetabular liner, and the 36 mm diameter femoral head was used along with self-tapping bone screws. This was a post-operative picture which shows the new implant. In the post-operative period, patient's limb was kept in abduction by the use of an abduction pillow. After the day 2 dressing, we had started him on toe touch mobilization along with a walker. We were able to mobilize the patient fast because of the use of the constrained acetabular liner. The technique of using a constrained acetabular liner increases the functional outcome of the surgery and prevents redislocation. Constrained acetabular liner can be used to prevent recurrent dislocations or in primary total hip arthroplasty in patients with high risk of dislocation or abductor muscle weakness. Thank you. Thank you.
What are the indications for revision arthroplasty other than this patient?
If there is any aseptic loosening of the implant of the prosthesis, or if there is a dislocation, or if the patient develops any other complications such as infection, we go in for a revision arthroplasty.
How frequently you need to get these revision arthroplasty? Because in the introduction slide you had mentioned that we are increasing the number of patients who undergo these.
Yes, ma'am. Revision complications in total hip arthroplasty range from around 5 to 10%, ma'am, in which the dislocation as such is about 2 to 3%.
It's quite common.
It's not very common, ma'am, but because of the increasing number of PHRs that are being done now, it will be common.
You have mentioned about constrained acetabular liner.
Yes, ma'am.
I don't have any idea. Can you explain to me?
Basically, there will be a acetabular cup inside which we put a polyethylene liner, and then the femoral head sits on the liner. This is the acetabular cup inside which there will be a polyethylene liner, and then the femoral head will sit inside the liner. So the constrained acetabular liner will have extra rim around it so that the femoral head will not displace. Basically, when we use a head which is larger in size, the distance the head travels from the center of the acetabulum to dislocate will be longer. So the head will not dislocate when you use a constrained acetabular liner.
This is an advantage.
Yes, ma'am.
Thank you.
Thank you.
Just one advice. When you put only the photograph, of course you have added videos here. When you put the photograph of patient, avoid revealing the identity.
Sorry. Yes, ma'am.
Black, right?
Any other questions? The topic is open for
First time why there was discussion.
So the patient had the alcohol and he fell again. He had a traumatic incident. So initially THR was done for avascular necrosis of the head. And then patient had alcohol, he had a fall, and he sustained the dislocation of the head. If he falls again, it will dislocate itself. But when there is a chance of dislocation, by using constrained acetabular liner,
we didn't give that time. Within 2 months, we went down and the dislocated. No, initially you can put this or it is only for revision arthroplasty. It is for revision arthroplasty.
So when we in conventional liners that we use, there will be more range of movements which is available. By using a constrained acetabular liner, we are trading off the range of movements. It will be little decreased. For stability, we are trading it off. Normally we use a normal liner, ma'am. In that, the range of movements which is achieved will be more. By using a constrained acetabular liner, the range of movements will be slightly decreased than the normal one.
So revision arthroplasty.
In revision, we use constrained acetabular liner.
no questions, then thank you.
Thank you.
The next speaker is Dr. Sindhu from department, PD from Department of OBC, and the topic of the presentation is traumatic withdrawal and bladder rupture due to instrumental vaginal tension.
Good afternoon. My topic is traumatic uterine and bladder rupture due to instrumental vaginal delivery. It is a case report done in collaboration with OBG department and urology department, headed by Dr. S.R. Mudunu sir and Dr. Vinay S. Kundargi sir. There has been a significant decrease in maternal mortality ratio in developed countries. However, in developing countries still suffer from a large number of maternal deaths. Very often, pregnancy itself can be a risky event in a woman's life. Globally, 80% of maternal deaths and 98% of stillbirths have been due to direct obstetric complications. These include hemorrhage, sepsis, abortion, preeclampsia, eclampsia, and prolonged or obstructed labor. Prolonged or obstructed labor is one of the most common preventable causes of maternal and perinatal morbidity. It accounts for 8% of maternal mortality. Obstructed labor occurs when the progressive descent of the presenting part of the fetus is arrested due to mechanical obstruction despite the presence of good uterine contractions. It requires assistance by either cesarean section or instrumental delivery. It can lead to complications such as sepsis, uterine rupture, bladder injury, and fourth degree perineal tears. The incidence of these complications are not as rare as we think. Prolonged and obstructive labor can lead to injury of the urogenital tract as well, which can be avoided by proper monitoring and early intervention. Case report. Name is Mrs. P. Age 30 years, from rural Yadgir district. Date of admission was 2nd of November, 4:30 p.m. Patient was referred from outside hospital in Bagalkot with complaints of abdominal pain, pervaginal bleeding, and involuntary passage of urine. This was following difficult vaginal delivery on 1st of November at 6 p.m. at a private hospital in Ilkal town. After delivery, she was referred to a medical college in Bagalkot where she underwent CT urogram. The urine was uterine rupture with bladder injury, and she was then referred to a medical college for further management. Patient had prolonged labor for which she had instrumental vaginal delivery. Previous reports indicate it was vacuum delivery. Weight of the baby was 4 kgs, indicating fetal macrosomia. She was parafor living for with irregular antenatal checkups at Ilkal town. The obstetric history was non-significant. On clinical examination, patient was conscious, well-oriented, pallor present, pulse was 72, SpO2 was maintained at 99%. On room air, BP was 110/70. CVS and RS were insignificant. Per abdomen, soft suprapubic tenderness was present. Uterus was well contracted and retracted. Local examination, episiotomy was present and intact. For speculum, cervical tear was present at 11 o'clock position, extending high up. Anterior vaginal wall tear was present with diffuse bleeding, and urine was draining from the vagina. Upper extent of cervical tear was not made out. Vaginal examination revealed a defect that was present in the posterior bladder wall. Provisional diagnosis is parafor living for with traumatic bladder and uterine rupture. Investigations, HB was 8.7. Remaining investigations were normal within reasonable limits. Management. Under general anesthesia, exploratory laparotomy, total abdominal hysterectomy, and repair of the bladder end was done by OBG and the urology department. Introp findings. Uterus was exteriorized and visualized. Upon inspection, a rent was felt in the lower uterine segment. Once UV fold was open, it was revealed that the rent was extending into the lower uterine segment. Cervical tear was present in the anterior lip of the cervix, extending downwards inferiorly to the vagina, and it was measuring about 8 centimeters with continuous bleeding present. The anterior vaginal wall a tear was present, extending downwards, whereas the posterior vaginal wall was still intact. A defect of 4 centimeters was noted in the posterior wall of the bladder in the trigone region, more towards the right ureter orifice, and edematous left ureteric orifice was present. Procedure, total abdominal hysterectomy steps were carried out. Vault was visualized. After that, specimen was taken out and vault was sutured. Then bladder injury repair was done by urology team with stenting. After that, bladder wall defect was sutured, leak test was done, and then omentum was placed between the bladder and the wall, and placement of pelvic tube drains. Postoperatively, intraop and postoperatively, patient's general condition was stable. IV fluids, IV antibiotics were given. Discussion. Obstructive labor is failure to progress in labor despite the presence of strong uterine contractions. These injuries are sustained when labor is prolonged, when there is use of operative instrumental delivery, when pelvis anatomy is abnormal, or any malpresentation or malpositioning of the fetus. These can lead to maternal fetal complications that increase the rate of mortality and morbidity. Non-obstructive factors also play a role. These include lack of regular
regular antenatal checkup, lack of proper hospital facilities and skilled manpower, lack of transportation in rural areas, and ignorance and illiteracy among patients. The key to prevention is early antenatal detection of malpresentation of fetus and abnormal maternal pelvic architecture, institutional delivery, and prevention of bladder injury by emptying of the bladder during delivery, early internatal detection of dysfunctional labor with the use of partograms, and judicious use of cesarean section. I would like to thank the Department of OBG and Urology for this case.
Dr. Sindhu. Before I begin the questions, I would like to congratulate the entire OBG department and urology department for successfully handling this case. What are the complications you expect from this patient?
Future complications from the OBG side, because hysterectomy was done, there is always a chance of valve prolapse in that case. But because the patient's age is also 30 years old, there is still that is seen more in older women. So as of now, complications would be more, I think, on the urology side of it. Urology complications would be presence. There's a chance of fistula fistula formation can again happen with these kind of cases, and possible bladder leakage. These cases, because we are a tertiary center, we're seeing more and more of these types of cases, especially because outside they will be mismanaged by smaller facilities which are not properly equipped with surgeries, OTs. So because of that, they'll try to find alternate ways of delivering the patient, which includes instrumental delivery. And because of that, even though it is more of an outdated process, we're seeing more of these cases.
Incidence of bladder injury in normal
Incidence of bladder
injuries are okay. Normal delivery and instrumental delivery.
Instrumental delivery incidence is not as rare as previously thought, because with normal delivery, with the instrumental delivery, especially use of forceps, because of its injury to the tissue, it can lead to necrosis, and it can lead to pressure necrosis, which can ultimately injure the bladder. That
There are two different things. Pressure necrosis occurs in instrumental delivery and obstructive delivery.
in obstructive delivery, and that can lead to further trauma when instrument is also applied.
Without instrument also they can form fistula and obstructive delivery. There is pressure necrosis. But there is present late, not the first. So what might be the cause of bladder injury?
Cause of this, we are suspecting that even though it was given that vacuum delivery was done, we're suspecting that it was forceps delivery because of the extent of the damage. Usually vacuum will not cause this type of extensive damage, whereas forceps, because they're applied more in the upper part of the vaginal wall, it can lead to this type of damage.
All forceps delivery won't lead to this. So in this case, what is the cause for bladder injury in this pregnancy?
Bladder injury, it was one fetal macrosomia was present. So the baby weight was 4 kgs, which in normal conditions we would be taking this case for cesarean section. So whenever fetal macrosomia is present, that excessive pressure given by the head of the baby can lead to bladder injury as well as tears on the cervical.
Would you have cured the uterus there?
No, sir. In this case, the extent of the trauma was so extensive; it extended from the uterus to the cervix to the vagina, and also looking at the patient's history, she was para for living force, so she has completed her obstetric family. So that as well as this extensive damage made it this as the best option for this patient.
Were there any injuries to the newborn baby?
No, ma'am. Baby was fine.
What are the complications is expected if the patient is not discharged?
There's always a risk of infection in these type of patients. There's a risk of future formation of fistula formation. There's a risk of her normal bladder, normal chance of urinary retention. And
Injury was extending up to the bladder line. One thing and posterior, the nerve supply is always from posterior. So they may have neurogenic bladder line features, and they may not empty properly once you remove the catheter. So these might be the problem. Along with fistula formation, the second and fistula formation later on. And ureter was also very near. Adjustment, ureteric pictures later on can develop. They may, once you remove the stent, they may have, but there will be devasculation of the ureteric wall also. So all those things can be a possibility. You have to follow near treatment.
Thank you. So we are done with the oral presentation, I will now request Dr. Krishna, and she's going to make a poster presentation on the topic acute urinary retention in adolescent girls attending to hepatitis corpus. A case report is from Department of Physics.
First. Good afternoon, everyone. Today I'll be presenting a case report on acute urinary retention in an adolescent girl secondary to hematocorpus. Introduction: it is an acute urinary retention in adolescents due to various causes, among which imperforate hymen is one of the rarest causes. The incidence is of 1 in 2000. It can lead to urinary retention rarely, and hence we present here a case of acute urinary retention in a 14-year-old girl with imperforate hymen here. She presented with history of urinary retention of 1 day. Multiple catheterizations were done prior to coming to our hospital here, and she gives history of menarche was not attained. And upon examination, abdomen was moderately distended with mild suprapubic tenderness, and external genitalia had bluish gray bulge, which is posterior to the urethra, is present. The ultrasound features here were present, was seen as a hematocorpus picture of 7 into 10 centimeter that was lying posterior to the bladder in the vaginal canal. She had underwent hymenotomy the next day using cruciate incisions were taken with drainage of hematocorpus, that is seen in these pictures here. Dark tarry blood was coming out from the vagina after giving central incision on the hymen. The edges of the opening were everted and minimally they were trimmed so as to prevent defloration and sutured with delayed absorbable suture, chromic advent number 1 here. She had an uneventful hospital stay and was discharged on the 5th post-op day, was followed up in gynecological clinic. Discussion: the failure of endoderm of urogenital sinus to completely canalize results in imperforate hymen. The incidence ranges from 0.01% to 0.5%, and good evaluation at birth could also pick up these earlier. However, they're not notified until puberty occurs. Symptoms due to collection of the menstrual fluid in the genital tract begins to appear, but menstruation apparently would not be started. Imperforate hymen has varied presentations. If at all, if it is present as an abdominal mass due to the pressure on the urethra, that can lead to urinary retention and dysuria. In cases of, if it is present due to the pressure on the rectum, it can also lead to constipation and dyschezia. Differential diagnosis would include other obstructing anatomical defects such as urogenital sinus leading to transverse vaginal septum, labial adhesions, or distal vaginal atresia. Correction of the imperforate hymen required in symptomatic prepubertal patients. Earlier diagnosis does not warrant early treatment, although it may spontaneously open up during puberty due to estrogenization. Surgical management of these cases is done by incision of the hymen at 2, 4, and 6, 8 o'clock clock positions, and the quadrants are cut and the mucosal margins are approximated with fine delayed absorbable sutures. If the hymenal tissue is cut too near the vaginal mucosa, it can result in
scarring and stenosis, which can further lead to dyspareunia. Unnecessary intrauterine instrumentation is to be avoided as the tissue is very fragile and can lead to perforation of the uterus. The conclusion, imperfect hymen is a diagnosis which should be kept in mind in case while treating acute urinary retention in adults and girls. Virginity sparing surgical approaches to case of imperfect hymen is desirable. Thank you. Ma'am, they would be brought by the parents because they're anxious enough. They come with not attaining menarche most of the time because their secondary sexual characters will still be present because it's not a hormonal problem. It's more of anatomical defect. So they would come with this presentation of not attaining menarche, and when we would examine them, and incidentally, then we'll find the bluish gray membrane that is present, the bulging, and then they would sometimes have cyclical pains, which is not that common also. Because initially during menarche time, the woman would not, the girl would not have proper hormonal secretions, and so she would come with incidentally they'd get her to the hospital. She was catheterized in outside, sir, where she was not diagnosed with imperfect hymen. Upon when she had come here, we had diagnosed her. No, sir, she could not. After catheterization, she could void. And that was happening twice or thrice. She was 2 to 3 times outside. She gives history that she had gone to multiple hospitals. She was catheterized, then she passed urine. She was admitted for 1 to 2 days, and then she was discharged back home. So the problem kept continuing. She came without the catheterization. After removing, she voided. Again, she presented with acute urinary retention. Sir. She had similar complaints, recurrent. Episodes, ma'am. So she had given vaguely 2 to 3, she said, sir. Yes, sir. So the day when she when she had presented to us, she gave 24 hours of not passing urine, sir. So we considered it acute. She had, but she said she had recurrent symptoms of the same kind.
I call upon the next presenter, Dr. Namita from PT in ophthalmology, and this is presenting on OCT findings in resolving both coil and Harara disease.
Good evening, everyone. I am presenting here a case of Vogt-Kanayagi-Harada disease. In this, how OCT finding change, pre-treatment and post-treatment with just corticosteroid therapy. And we are monitoring the vision change and OCT finding in this. This case was seen by Dr. R.K. Ijari, Department of Ophthalmology. So, Vogt-Kanayagi-Harada disease is a severe bilateral granulomatous intraocular inflammation associated with serous retinal detachment, disc edema, vitritis, with eventual development of a sunset low fundus. Sunset low fundus is there is a choroidal atrophy following which due to after the when the disease is progressing and final after the chronic stage. This is the sunset low fundus due to multiple atrophy and non-atrophic layer of choroid. It is an autoimmune inflammatory condition mediated by T cells that target melanocytes in the individual susceptible to the disease. So the melanocytes are present in the retina, uvea, and the ears. They target those cells. The in this we the here is a report of patient who was 40 years male presented with sudden onset of diminution of vision in both eyes for 2 days. The vision being counting fingers 3 meters in right eye, and in left eye the vision was 6 by 36. The loss of vision was not associated with pain, photophobia, watering, or any discharge. The patient was non-diabetic and not hypertensive. There was no similar complaints in the past. Anterior segment findings were normal, and fundus findings we see in the image here uh, showed multiple serous detachments here, and more they are on the inferior arcades and around the optic disc. These are all the serous retinal detachments, and these are the detachment is also seen around the macula and optic disc. The findings are more severe in the right eye, and the OCT finding which we were seeing, it shows multiple serous retinal neurosensory sensory detachment, suggestive exudative retinal detachment. Exudates are present between the retinal pigment epithelium and neurosensory retina, and there is multiple subretinal septi we see in this in multiple quadrants of the and more this neurosensory detachments are more seen in the foveal region in both the eyes. However, four findings of the OCT were more in the right eye than the left eye. In the VKH, there are four stages like prodromal, acute uveitic, convalescent, and chronic recurrent stage. In the acute uveitic phase, we will see initial choroidal thickening developing in multiple choroid segments of inflammation. And after this, there is breakdown of retinal pigment epithelium, which results in serous retinal detachment. This retinal detachments can be evaluated both by OCT and fluorescein angiography. In fluorescein angiography, we see multiple pinpoint hyperfluorescent dots, but here we are seeing OCT only. And then we treated this patient with oral dose of prednisolone 40 milligram for 3 days, and there was a drastic improvement of vision from counting fingers 3 meters of the right eye to 6 by 12 in right eye. And the OCT findings also improved partially in third eye. We see how there are subretinal fluid and septi in this, and immediately after 3 days there is the fovea appears normal and the septies are gone and no detachment is seen. Similarly, with the fundus photograph, we see the retinal detachments have almost gone. This after the OCT findings after the 6 days were all normal following the treatment of prednisolone, and OCT has this thus showed that allowed for specific delineation of changes to the retina and retinal pigment epithelium that were otherwise less evident on clinical examination like fundus. But if we see in OCT, immediately we can see the difference and progress of the disease and also improvement in the vision. So VKH is a severe inflammatory disease, but prompt and aggressive treatment may lead to better visual outcomes. Systemic high-dose corticosteroids are the main cornerstone, even if there are other treatments, but still the previous treatments like high-dose corticosteroids are the mainstay of treatment. And thus we can see OCT continues to be an impressive technology, allowing us to understand more about the disease progress of VKH, and has been valuable in visualizing improvement in subretinal fluid, retinal thickness, choroidal thickness with successful therapy as well as visual disease recurrences. That's it. Okay, sir. Optical coherence tomography. It is the layers of the retina are seen in that. We see here, and we see fluids placed between the neurosensory retina and the retinal pigment epithelium, and these are the septi. Ma'am, 40 to 60 years male. Yes, 40 to 60 only, not younger, not older. Male, male, yes. Yes, the skin manifestation like poliosis, vitiligo, they can be developed, but this infection, it was not there. Uh, I were there. OCT findings were very predominant, and with prednisolone, there was drastic improvement in the almost in 3 days with oral steroids of 40 milligram. After that, we followed up with a tapering dose, and with 9 days, the retina was almost normal, and vision was almost 6/6 by the end of 9 days. Yes, yes. This patient didn't have, and no, no other findings patient had. The prognosis is good with corticosteroids. If oral is not working, we can give IV methylprednisolone about 1 month. After that, if it is not working, you can go to suppressive agent like cyclosporin, and that's it. And if not, biological blockers like infliximab. The prognosis is good. The study was mostly concentrated on how we can see the difference with OCT. Uh, he was coming for 15 days. After that, when his vision improved, he stopped coming. Yes. Most no. The patient, we have seen 2 patients, they didn't have relapses. Is is sufficient. Almost 100% predictive value is there due to the subretinal fluid and the septi present. It has 100% predictive value. It was Vogt-Tanagi-Harada disease, but if there were other manifestation, it would be just additional.
No other questions? Thank you, Dr. Lamita. The next speaker is Dr. Lata from Department of OBG, and the topic of presentation is maternal and perinatal outcome in pregnancy with epilepsy, a 5-year registered study.
Good afternoon, one and all. I'm Dr. Lata from OBG department. Today I'm presenting a poster on maternal and perinatal outcome in epilepsy. It's a 5-year retrospective study. Epilepsy is a common neurological disorder affecting 1% of the population in India. The prevalence of epilepsy at any point of time has said to be 6.3% per 1,000 persons. Epilepsy has been known to be associated with an increased incidence of maternal obstetric complications. The objective of this study was to analyze the effect of epilepsy on the maternal and perinatal outcomes in pregnant women. Materials and methods. It is a retrospective observational study, and the study was conducted in BLDE to BM Patil Medical College Hospital and Research Center and Bhagavati Hospital, Vijaypura. It was conducted from 2015 to 30th September 2020 and was collected, the data was collected from the medical records, case files maintained at the hospitals. Inclusion criteria, all the pregnant women who were diagnosed to have epilepsy prior to conception at BLD hospital and Bhagwati hospital were included in this study. And any other cause of seizures other than tuberculoma and tumors of the brain, intracranial space occupying lesions like meningioma, etc., were excluded. And the results were during the study period, a total of 17,613 women delivered in these two hospitals. Only 41 patients were pregnant women with epilepsy. Out of which 70.7% of the women undergone LSCS, and most of the women were belong to multi-gravida. And there were out of 41, 10 pregnant women with epilepsy had recurrent seizures, out of which like 5 of them were only on monotherapy, levetiracetam, and 2 were on polytherapy, which was they were taking levetiracetam and phenytoin and phenobarbital, and 2 of them were taking carbamazepine and clobazam. Most of the babies were full-term babies with weight ranging from 2.5 to 3.5 kgs. And levetiracetam was the most common monotherapy anti-epileptic drug used, and it was also used in polytherapy. It is a second generation drug and has been studied extensively and has found not to be associated with major congenital anomalies. Various studies have shown that epilepsy is associated with abruption placenta, higher incidence of induction of labor and cesarean section, stillbirths, preterm labors, and small for gestational age, and low CAR score, congenital malformations. On our study, there was no such increase in any of the complications except for a large number of women undergoing LSCS. And pre-pregnancy counseling is of utmost importance and can help to reduce the burden of the disease on pregnancy. With the shift of use of second generation anti-epileptic drugs for the treatment of pregnant women with epilepsy, the maternal and perinatal outcomes are promising. Thank you, ma'am.
What percentage of women with primary?
36.6% were primary, ma'am, and 63.4 of the percent were multigravida.
And the uptake is being multi-gravida, previous delivery just by
In that only like around 33% were normal delivery, ma'am. Rest were LSCS, ma'am.
What are the company was to discuss? So your handle is maternal derivative also.
Yes, ma'am.
You didn't find any other complications there except for the increased incidence of the delivery cycle.
Yes, ma'am. There were no other complications found, ma'am. In various studies which were done previously, showed like many other complications because they were conducted from so many years, and they were using even the first generation anti-epileptic drugs, which showed like many complications, ma'am, like congenital anomalies in the babies.
What percentage of mothers were on treatment anti-epileptic drugs?
All the 41 pregnant women were under treatment. Yes, ma'am. Yes, ma'am.
Okay, it was continued even during pregnancy and those drugs were paid during pregnancy.
Yes, ma'am. Not all of the drugs, ma'am. Few patients were on first generation drugs, ma'am, but they didn't turn out showing any complications. Yes, ma'am.
You didn't observe any severe complications.
No, ma'am. But most of them were on levetiracetam, ma'am. Almost like 48.8% out of 41 like in the 41 pregnant women, like 48.8% were on levetiracetam only, ma'am.
The topic is open for discussion.
Sir, like they showed complications, sir. So safest drug was second generation drug, sir. Now it is, yes, sir. No, sir. No, we are not giving now, sir. Thank you, ma'am.
I would like to thank all the presenters for their wonderful presentations. Now it's a time for certificate distribution. Ma'am, please. Prachi.